Hi, I'm Dr. Vidushi, and in this video we describe the different phases of a white cataract that can be encountered in clinical practice. Now, one of the most difficult things in the management of a white cataract is the capsule management because of the positive endolenticular pressure, poor visualization of the anterior capsule, and the fact that sometimes the capsule may be thick, friable, calcified or fibrotic in these cataracts, which makes capsulorhexis extremely difficult. Now, as you can see here, this is a white cataract with milky fluid inside, and as soon as we initiate a capsulorhexis, we see the Argentinian flag sign or a torn anterior capsule. One may make many attempts to salvage this capsule and to convert it into something like a capsulorhexis, but the case from here on becomes extremely difficult. So the best way to manage these cases is to do some sort of a capsular dye staining, which makes the capsulorhexis much easier. And as soon as we see the egress of milky fluid, we must aspirate it using either a cannula or an irrigation aspiration probe of the Phaco machine or the Phaco itself, so that the positive endolenticular pressure is decreased, and then tamponade it with viscoelastic. And as you can see here, the rhexis has been successfully completed. This is one of the most difficult steps in the management of a white cataract. The dye staining can be done using the ultimate soft chill technique, where we first inject viscoelastic into the anterior chamber, then create a pocket of BSS underneath the viscoelastic and stain the dye in this pocket of BSS, which then makes the subsequent capsulorhexis much easier. Now here again, this is a milky white cataract, and after tamponading the cataract with viscoelastic, we initiate a capsulorhexis. Here no dye has been used, and the rhexis can be performed without a dye as the surgeon gains experience, but we see a lot of milky fluid that has come out, which needs to be aspirated using a cannula. The positive endolenticular pressure needs to be counteracted repeatedly by injection of dense viscoelastic into the anterior chamber so that the rhexis does not run away. And after that, we can again proceed with the capsulorhexis. Now in this case, we see a case that has had previous radial keratotomy with a white cataract, and again, as the surgeon gains experience, a capsulorhexis can be performed without using a capsular dye, but this must only be done once we are comfortable doing this procedure. Otherwise, a dye is normally recommended. Because the positive endolenticular pressure poses special challenges in these white cataracts, several other techniques have also been described. For example, the use of an ND-YAG laser preoperatively to create an opening in the anterior capsule, which allows the egress of milky white fluid from the white cataract, thus reducing the endolenticular pressure and making the subsequent capsulorhexis during the surgery much easier. Now, the nucleus in these white cataracts can range in hardness from soft white cataracts to extremely hard cataracts. This is a white cataract which can fairly easily be phacoemulsified, and as we can see here, it is not unusually difficult. The white cataract can easily be seen against the red glow, and we can easily remove the white cataract as it is not very hard. We must remember the step down technique for removing the last piece, however. Here, as we see, this is a white cataract with a fibrotic capsule where the rhexis is difficult to perform. So the capsule is being cut with Vanna scissors in an attempt to complete the capsulorhexis. However, a zonular dialysis has also been noted in this case. So this is an extremely hard brunescent cataract which is masked by a white fibrotic capsule. And in these cases, we need to use ancillary techniques like the placement of a capsular tension ring here, which is done to stabilize the capsular bag and to prevent any further stress onto the zonules during the phacoemulsification. In some of these white cataracts, it is a good idea to implant the IOL before removing the last piece so that the posterior capsule is protected and is not damaged. Now, there are many other variants of a white cataract. This is a traumatic white cataract in a young adult caused by a thorn injury, and there is a pre-existent anterior capsule opening, and therefore no capsulorhexis has been performed. The soft white cataract can easily be removed using just the irrigation aspiration, and now the opening in the anterior capsule is clearly seen. In this child, or a young adult, a Technus multifocal IOL implant was placed. IOL is being implanted in the capsular fornices through the opening that was already present in the anterior capsule. In all these cases, as it is quite likely that we would have used a lot of viscoelastic, it is extremely important to remove all the viscoelastic from the capsular bag, especially from under the IOL as well. Now this is another variant of a white cataract, which is a cataract caused in a case of chronic uveitis. This is a cataract which also has a small pupil due to posterior synechiae. After the injection of Healon 5 into the anterior chamber, we use 2 Kuglin hooks to stretch the small pupil and to enlarge it in an attempt to be able to perform phacoemulsification. This kind of a pupillary stretch technique is used only in a very few selected cases because one, it may cause permanent enlargement of the pupil, and secondly, this releases prostaglandins into the anterior chamber, which causes postoperative inflammation. Besides, this technique is only useful in cases of fibrotic irides, as are seen in the cases of chronic uveitis, and should never be attempted in small pupils due to floppy iris. Here, the fibrotic capsule capsulorhexis is being performed without using a capsular staining dye. Of course, this should only be done once we have had sufficient experience and are confident about performing this sort of a capsulorhexis without a dye. Now, this is another variant where the cataract is extremely hard and calcified and has been removed actually using a vitrectomy probe, and such kind of dense, hypermature, calcified cataracts can still sometimes be encountered. Now, for some of these white cataracts with extremely thick, fibrotic and calcific anterior capsules, a femtosecond laser cataract surgery platform may be very useful to perform the capsulorhexis. For example, in this case seen in here, where a manual rhexis may be next to impossible. In these clips, a Victus platform has been used to perform a rhexis, which is also useful in cases of intumescent white cataract, as the risk of a runaway rhexis here is very high, as well as in the thick fibrotic capsules seen earlier. So to summarize, capsulorhexis is one very important step in management of these white cataracts, but the availability of newer capsular dyes, high viscosity OVDs and new phaco machines with excellent fluidics and parameters have now made it possible to manage these cases in their different forms without any significant complications. Thank you.